Podcasting from a remote location, nowhere near the heart of New York City. This is Crypto Characters, and I'm your host, Jason Nagi. Our guest for today, and we're very lucky to have this, is Dr. Shreni Zinzuwadia, an ER doctor for the last 14 years, working here in northern New Jersey. Dr. Zinzuwadia, or Shreni, shall I say, welcome to the podcast.
Hi, thanks for having me.
So why don't you tell us a little bit about yourself, and then we can kind of go into what you're seeing as an ER doctor in New Jersey. We're going to be talking about COVID-19 today.
Sure. Okay. So I'm emergency medicine trained. I went to med school at New Jersey Med School in Newark, New Jersey, and I did my training in the Bronx, Albert Einstein College of Medicine, Montefiore and Jacobi, and then I came back to New Jersey. I've also worked in Brooklyn, so I've been doing emergency medicine for, in total 14 years, and mostly inner city and some suburban hospitals, some rural hospitals. So I've worked as far as Maine and worked in the Bronx, Brooklyn, New Jersey, Newark, and the suburbs. And what we're seeing is quite a unique situation for us. Like we're usually very, what we're used to is heart attacks and strokes and appendicitis and, collapsed lungs and brain bleeds and diverticulitis and gunshot wounds and knife wounds. And all we're seeing right now is everybody has COVID-19. I work at 3 different hospitals in northern New Jersey, and all of our patients have COVID-19. Everybody.
Every single one of them.
Literally. I mean, I could say maybe one person per shift doesn't have it. I had one straightforward appendicitis, and I had one woman last night who was 27 weeks pregnant who had a headache, but even her, I was suspicious she had COVID-19, even though she didn't have a fever. And I had one patient with sciatica, but literally every single patient's coming in with symptoms of COVID-19, which range from the typical, most common ones are shortness of breath with headache and fever and body aches and cough. But there's other outlier symptoms like abdominal pain with some diarrhea, just vague unwellness, decreased appetite, loss of smell, fatigue. So there are non-specific complaints that also make us very worrisome for COVID-19.
So let's talk a little bit about what we know about the virus, or at least its symptoms. Well, before we get to the symptoms, how does it spread? Do we know that yet? I know there's a lot of talk about things, but no one really seems to know. And
no one knows, because no one ever knows exactly how any respiratory virus spreads. I was actually doing a lot of reading up on this, and respiratory viruses, they get into your respiratory tract. They cause these symptoms of cough, congestion, body aches, maybe shortness of breath, depending on how severe they are. And there are a bunch of them. Little kids get RSV, respiratory syncytial virus. It's a common one that causes bronchiolitis in young children, and there's nothing to do. A lot of people say the COVID is like a nasty bronchiolitis for adults, super nasty, ultra nasty respiratory syncytial virus for adults, in that it causes this huge inflammatory response. But how are these viruses spread? So it's all theory, because you can't actually see the viruses, right? These are microscopic particles. You can't see them with the naked eye. So how do you can't see the transmission. There's a theory that it's spread through respiratory droplets, that it's big enough to be spread through respiratory droplets. So if I cough, and I cough on you and you breathe it in, I give it to you. That's the theory. Or if I speak loudly and there's spittle coming out, or if I speak aggressively and there's spittle coming out, and I'm close enough to somebody else, they'll inhale it and get it. That's the thought. The other theories are, you touch something, the virus lives on some surface, you touch that surface, you do this, you spread it to yourself. You spread it to your own mucous membranes, you inhale it, or you wipe it in your mouth and it gets in there and it infects you. These are all theories. These have been the long-term theories on how respiratory viruses are spread, but there's no camera to film it. There's no proof of any of this. This is just the long-held belief that respiratory viruses are spread through the respiratory tract from somebody else's respiratory particles popping out into the air and getting into somebody else's respiratory tract, or living on a surface for 3 to 4 hours. And in those 3 to 4 hours, or whatever the hours are for whatever the surface is, you pick it up with your hands and you self-inoculate by touching your face. Again, these are theories. No one ever really proved how the flu was spread. There's no proof that the flu is spread the way we think it's spread. And there's no proof that corona spread the way we think it spread, but we don't have any better ideas. These are our best ideas, and they seem to be reasonable, so we go with them.
Well, and my next question was going to be, what information are we missing? But it seems like we're missing nearly all of the information. I mean, is that correct?
Yeah, but we have been forever, right? The flu's been around for hundreds of years, and there's no more proof of how it spread today than in the past. There's excellent theories on how it spread. Same thing with coronavirus. This is a novel virus, so the thought is that people are affected so badly, the people that are, because they have no immunity. They've never seen it before, so they're getting hit very hard with it. It's a brand new assault to our immune system that has no memory of it. So there's no memory helper cells, no memory immune cells to help fight this. In that, if you get exposed to a virus, the second or third time you get exposed, your immune system remembers it and it mounts a response very quickly before you get sick. But that's not happening with corona because it's brand new and none of us have seen it before. The thought is that kids don't get as sick as adults because they do get infected with coronaviruses. They get infected with all kinds of viruses, little kids. They get enterovirus, rhinovirus, RSV, coronavirus. So maybe their immune systems are more equipped to handle this because they've seen similar things before, whereas adults have not. That's one theory out there. And the other theory is maybe something happens hormonally when you hit puberty that's different from when you're a child. The children are doing so well. There are so few sick children, if any, and I'm talking under 12 years old with coronavirus. All of the pediatric cases of coronavirus, they're older than 12 years old. And it's rare to see 18-year-olds, but there are some, and it's rare to see young 20-year-olds, but there are some that are sick. So this is a disease that's hitting adults very hard.
So now you talked about old versus young. Is there any, I know that in some of the Eastern traditions of medicine, and I've seen this with children whenever they're hurt, they tend to bounce back a lot faster. Is there a belief that that's kind of what's happening, or is that really another species of what you were talking about earlier with the way that children get infected and the reasons why they're not showing corona?
Yeah, do you mean
symptoms?
Rephrase that for me. Say that for me one more time.
So I know that in certain respects, I don't know if this is a Western medicine perception, but there are cultures with medical perceptions that children tend to heal faster than adults, and I've seen that.
Right.
Is there any belief that there's a connection between old versus young and the immune systems of children that makes them more resilient towards corona?
That's a good question. That I don't know too much about. I can say that all of the younger people that I've seen sick with corona, and when I say younger, I mean 20s, 30s, 40s, that I see sick with corona, they're not in perfect health, right? So they either have one or two underlying diseases, maybe a remote history of asthma, some kind of respiratory vulnerability. They're not in cardiometabolic fit shape, so they're overweight, not really in top shape, so maybe they're vulnerable. So morbid obesity puts a lot of people at risk. When they seem like they're totally healthy, they'll have one of these. If you look really carefully at them, they'll probably have something in their medical history that tipped them over the edge. But we don't have the data yet. I mean, I have a friend who's an ER physician who got coronavirus, and she is, mid 40s, very healthy, no medical problems, eats great, and she got it, and she's been homesick for 14 days with fevers of 103. And, if she walks from her bedroom to the bathroom, she gets completely winded and drops her oxygen saturation to 88%. This is a very healthy, seemingly very healthy, strong immune system, typical middle-aged young adult. So I don't think the data is out yet as to why it's hitting some people who appear very healthy. It's still hitting them hard. It's not hitting them maybe as hard as it's hitting other people, where they're getting intubated, they're going into the cytokine storm, the inflammation is out of control, and then they arrest and die. But it's hitting them hard in that they're very, very symptomatic, scarily symptomatic.
What's a cytokine storm?
That's
right before death, or is that just what happens when you get sick with any virus?
No, that's what happens when you hit this level of inflammation that your body's immune system is now revved up so much that the inflammatory response is so great, we call it a storm. It is now a storm in your body that is just kind of self-perpetuating and going a little crazy in fighting this little virus, So this little virus comes in, and then all of a sudden, at some point, this big storm is triggered, and that's what causes people to spiral in a bad direction and get sicker. And it's hard to bring them back from the storm once the storm hits. It's hard.
You hear people talk about medication and how to treat it, which has now become strangely and foolishly a political issue that I don't really understand. But are there any treatments outside of a ventilator to help? I mean, I've heard people say, I've heard people talk about people who have felt like they were on death's door and they've taken, what is it? Is it hydrochloroquine? Hydrochloroquine with zithromycin?
Yeah, that's what's being used commonly. And it's hard because the original data for hydrochloroquine is very weak. So the original studies that are being used to promote hydrochloroquine are very weak, poorly done studies that nobody respects. So we're still using it because we don't have anything else to give people. The same thing with azithromycin. It's not really clear that it's doing anything, but we don't have anything else to give people. There was a recent study that somebody shared with me that very, very high doses of vitamin C are showing some promise. So if you go into the functional medicine world, in terms of promoting your immune system and immune health, there's a list of things that you should be taking every day, right? So you should be taking big doses of vitamin C,
Right.
200 milligrams of zinc, magnesium every day, quercetin, which is a flavonoid. Let me see, what were the others? There are a couple of different other ones to kind of keep your immune system strong and robust so that you don't get sick. So I think it's interesting that vitamin C and vitamin D are showing promise, but these vitamin A, vitamin D, vitamin C, magnesium, zinc, all promote immune health. So if let's say your levels are low, then theoretically your immunity is going to be weak and you're going to be susceptible to disease. But if your levels are high, then theoretically your immune system's healthy and maybe you can have a bigger, tougher response before the virus gets you sick.
So a lot of it's preventative then.
Yeah, I think the money's going to be with preventative and not getting very, very sick. Because once you get very, very sick, there's some literature out there that steroids will work when people are sick. The data for hydrochloroquine is not that great, but we're using it. The data for azithromycin is not that great, but we're using it. And then that's pretty much it. And oxygen, and oxygenating people, because this is a very low oxygen disease, meaning that people are not able to get oxygen. They're hypoxemic. They're hypoxic. They can't get enough oxygen. And that's the problem. So once you get very, very sick, there's not a ton of medicines out there. So preventative would be better, would be ideal, but not to get sick.
What have you seen with the effect of the current medication regimen that people are getting when they're on the very edge? I mean, is this something you should be taking right away? Because I've heard reports that it's not something that you should take preventative, and doctors are now recommending that you don't want to take it right off the bat. You really want to wait because you don't want to use it unless you need it, and many of the people that have these symptoms don't ultimately require.
You're talking about the hydrochloroquine and the azithromycin. Yeah, we usually don't give that to healthy people. So healthy meaning you have symptoms, you have a fever, you have body aches, you're short of breath, but I check your pulse ox, I walk you around the room, and your pulse ox doesn't drop below 92. That's kind of our threshold. 95 and above is normal. If people are teetering between 92, 93, and 95, we're like, you're good enough to go home. Here's some stuff to boost your immune system, but there's no indication for hydrochloroquine or azithromycin when you're not that sick. Now, I had a nice young man, 51 years old, no medical history.
That's generous, by the way.
Huh?
That's generous of you.
Who came in, he's a truck driver, and his wife had coronavirus, and I think she beat it. And he came in, it was his third visit to the hospital. He came 2 previous times where he wasn't that sick. The first time he wasn't sick enough to be tested because he had no fever and he looked great. So they said, yeah, your wife has it, so you probably have it. Go quarantine. You're not sick enough. Oh, I lost you for a second. You're not sick enough for us to do anything. Okay. And then he came back a second time feeling worse. And he was waiting. The wait time was really long. He said he waited 4 hours. He didn't get tested because he couldn't wait anymore, and he went home. The third time is me. I saw him, and at this point, he got very, very sick. It's not that something could have been done when he wasn't sick. Nothing could have been done when he wasn't sick, except maybe build his immune system with vitamin C and zinc and vitamin D, etc. But there was no medicine to give him when he wasn't that sick on those first 2 visits. On the third visit, he had to call an ambulance, and he came in because his pulse ox, his oxygenation was between 70 and 80. That's really, really low. So you can't really survive like that. You need oxygen. So he came in, I admitted him to the hospital. I put him on oxygen. I ordered all the COVID blood tests that we're doing routinely to assess how sick they are for steroids, hydrochloroquine, and azithromycin. That's really what we're offering in terms of medication now. So we do this slew of lab work, and if the numbers are really high, or if their oxygen need is really high, we start those meds. Once the oxygen need is really high, it's not even the fever, it's just how hypoxic are they? If they're hypoxic enough to need a lot of oxygen, then they're getting medication and getting admitted to the hospital.
And which really brings me to my next question, which is when should you call a doctor? When should you go to the hospital? When should you call an ambulance? I mean,
Yeah.
it sounds like it's just if you feel bad. And do you feel bad, okay, bad, or really bad? Is it that simple,
Yeah.
or is there more to it?
Well, that's the problem, right? How do you teach patients to do that, right? So some people say, I feel really terrible and I feel like I can't breathe. And then you do their pulse ox and it's 96, 97, 98%, which is basically normal. They feel really bad and they feel short of breath because they're fighting an infection and they're sick. So their subjective feeling of I can't breathe doesn't match my objective measure of their oxygen. I send them home. So what do I tell people? Are they going to keep coming back every couple of days because they're like, well, I still can't breathe, but the oxygen level's normal. So I try to give them something to measure. And I got this from my ER doctor friend, Dr. Carrie Chang, who works with me. And I said, what are you telling patients? And he says, well, I tell them this. I say, if you can do this, 1, 1,000, 2, 1,000, 3, 1,000, 4, 1,000, 5, 1,000, 6, 1,000, 7, 1,000, 8, 1,000, 9, 1,000, 10, 1,000, without getting winded, you can stay home. If you don't think you can get through that because you're so winded, come to the hospital. Or if you can't walk from your bedroom to the bathroom or your bedroom to the kitchen, if you can't walk 10 feet without feeling really winded, you need to come to the hospital if you feel really winded doing that small stretch. So it's hard because how do people measure at home how they feel? They're in a panic. They're terrified they're going to die of this disease when some of them are not that symptomatic yet. So I try to give them that objective measure to kind of assess themselves. It's not easy. It's not easy.
That's a great test because everyone, I'm sure that if you have a cough right now, or if you're suffering from the flu and you don't know it, you really want to know what you should do and when you should go, because the last thing that you want to do is go to the hospital when you're going to sit there for 4 hours, you're going to waste a lot of time, and maybe you're infecting other people, or maybe you just don't need to and you can rest. So that's great. So count to 10, essentially 1, 1,000 to 10, 1,000. And if you could do that, then you don't need to go to the hospital. I think that's something that everybody should know. So thank you.
Yeah. And then I had another guy who came in on his second visit for persistent fever. And he's like, I can't get the fever down. He took Tylenol. He took 2 500 milligrams of Tylenol. I couldn't get the fever down. So he kind of panicked and came in, and he waited the 4 hours because, now it's that many people are coming in. And he was fine. His pulse ox was 95%. So I sent him home and I gave him preventative stuff, vitamin D, vitamin C, zinc, gave him a list of 5 different things to take, lots of lemon water all day. And told him, just take more Tylenol appropriately every 6 hours and you'll get the fever down, but you're fine. I'm sending you home without medication.
So you just said lemon water, zinc, vitamin C. Tell me that actually helps you if you're not feeling well? That stuff actually works?
That stuff promotes immune health. I mean, I don't think there's major bodies of research about it, because who researches, preventative medicine? Nobody. There hasn't really been a lot of money and research put toward studying preventative health, which probably will change now. But, it's just a commonly known fact that vitamin D, A, B, and C promote immunity, good immunity. So what else can I offer patients? What else can I tell them to do to get themselves healthy? Keep their electrolytes up, chicken soup, Gatorade, lemon water, and then some vitamin supplements because they're not getting their levels tested. We don't know how much they have in their bodies. So why not take some vitamins that are known to promote immune health?
And what about nebulizers? I know they're used for asthma treatment, and you can take salt water and they kind of turn the salt water into something you inhale. And I know that we got one for one of our kids when they were very young, and we use that when any one of us has a really bad cough, for example. Does that help with COVID, or is that just it's not strong enough?
Well, if you're talking about nebulized albuterol versus nebulized saline, with COVID now, we don't want to use anything nebulized, because when you nebulize it, you're putting all those respiratory particles in the air and you become that much more contagious. It doesn't control the respiratory particles coming out of your face. It kind of spreads them even more to everybody around you. So for all our asthmatics and pulmonary patients that are coming in with COVID who we'd normally use nebulized albuterol on, we can't use it, or we're trying very hard not to use it, because it'll spread the virus that much more quickly and aggressively, because the nebulizer just kind of pushes everything out in the air. So we're using an MDI, which is a metered dose inhaler. It's a little machine that gives you 2 puffs. It's a closed system into your mouth, and we're giving people that albuterol version, not the nebulizer. Now, if you're talking about, that's another thing we do tell people, though, if we send them home, is to go in the shower with Vicks on your chest and get into a nice hot steam shower by yourself, so you're not infecting other people. And that's kind of a nebulized, steamy environment where your respiratory particles are filling the shower, but you're by yourself, and you're using that steam to kind of open up your airways and make you feel better. So that version of it we're using. But the nebulized machines we're not promoting right now because they spread the infection.
Now you talked about preventative medicine. Should everyone be running now because that helps your lungs, or is that just it's too late if you're doing it for that? You need to have started a while back.
That's a great question. I don't think it's ever too late. The younger you start, the better your health will be. But I don't think it's late for people like you and I. Like, I'm just getting started. Because of this virus, I just started taking elderberry every day and vitamin C every day, and a bunch of other supplements to boost my health, because my diet's probably not that great. I work lots of nights. I drink lots of coffee. I eat lots of snacks. I eat lots of junk food because I don't plan my meals, and my schedule's crazy, and my cortisol is depleted because I'm sleep deprived and stressed and high adrenaline situation. So I know my health isn't ideal. So I've just started taking lots of supplements and boosting my health. So I don't think it's ever too late, but the younger you start, the better off you will be, for sure. Well, I think people will take a turn toward preventative health now after this assault.
Well, I hope you do something about that, because we need doctors like you out there to make sure everyone's good, but also as a friend, want to make sure that everyone stays healthy, right?
Yeah, all the kids take vitamins. Amiri's taking vitamins. We're all taking supplements now. And we're trying to eat a lot better. We're trying to be a lot more thoughtful about how we eat and what we eat. It's a habit you have to learn. It doesn't come easily, not in this environment, And
the hospitals don't help the doctors with that, because that just hasn't been a thought, I guess, until recently.
You mean in terms of what? Preventative health?
Correct, yeah.
Yeah.
For the doctors.
Because Western medicine is it's evolved to take care of acute problems. It's an acute care-based model, meaning let's fix what's broken. It's never really focused on letting anything break. That's really been up to the individual to make their decisions and their choices about what they eat and exercise and lifestyle. It's been up to them. It hasn't been something that's been the forefront of healthcare in the U.S., because it's really been about fixing what's broken and acute care interventions, like cardiac caths for heart attacks and TPA for strokes and, surgery for appendicitis. It's always like, now you've got a problem. Now let's find a solution to fix it. But it's not, how do we prevent the problem from happening, which is, I think, where we're going to go now in the future, because there's nothing out there to fight this virus, right? There's no magic bullet to fix this deadly virus. You have to be healthy and be in that group that's going to be asymptomatic or have very low level symptoms. So I think we're going to shift directions.
So now we've heard this week and next week will be the toughest. Have you seen the arc? I mean, what's the arc been? I know that you started with brain bleeds, heart attacks, and shortness of breath, and people with gunshots and knife wounds coming in, and now it's all COVID-19. When did that start to change? Have you seen an arc? Has it gotten busier this week? Is it going to continue to get busier? You know, what
Yeah, I would say that I think it is going to be this week and next week. I really want this to be over by now. People were very good about self-quarantining. It's amazing. All of those patients that came into the ER, those 385 visits a day that I would see at one of my hospitals, or the 150 visits a day I'd see at another hospital for whatever complaint. I have a headache, my arm hurts, my back hurts, I have this weird cough, my eyesight's blurry, all of these symptoms. No one's coming in. They're really listening to the governor's, self-quarantining. They're not coming in for these not ridiculous, but these minor symptoms. People are staying home. We're like, where did all our patients go? All those patients that filled up the ERs all these years, where are they? They're home. So suddenly there's no real diverticulitis, appendicitis. It's not that common. So people are self-quarantining. I think I got lost in the question now. So they're not coming in, and everybody that is coming in has COVID-19. And what am I seeing? I'm seeing young, healthy people that are kind of sick. I'm seeing young, healthy people that are very, very sick. I'm seeing older people that are very sick. I'm seeing middle-aged people that are very sick, and I'm seeing some critical people. Last week, we saw a lot more critical people coming in, very hypoxic, not able to breathe, needing to be put on a ventilator immediately. I'm seeing a little bit less of that now, but there have also been a lot of deaths. A lot of people have died already from this.
And I guess which is really, that's terrible. And that's kind of what I was talking about. So the arc. So you started with maybe 10 patients 3 weeks ago. Now it's 50. Now it's 100. Are the deaths coming? Kind of like, where are we in the cycle? What are you seeing?
I'm starting to feel like it's plateauing, but that's anecdotally just my own personal experience that I'm feeling. All our hospitals are at 90 and upwards of 90% of capacity. Like all the hospitals I work at are full. Basically,
for ER or for everything?
For COVID. It's amazing how it's happened. All of the units have turned into COVID units. Like many, we're talking like 150 inpatients with COVID, maybe 70 ventilated patients at 2 different hospitals, which is a massive amount. Most hospitals have 20 ICU beds, and half of those beds are in use. They're not all intubated. We're talking about 60 to 70 ventilated ICU patients in 2 different hospitals, and we're talking about 150 to 200 inpatients. One of my hospitals has 385 inpatients. Their capacity is 450. They're at 80% capacity, all COVID.
All COVID. So that's actually, so from the ER perspective, at least, it's more than 3 times of an increase. In general, people coming into the ER and in nearly full hospitals, all from COVID.
Yeah.
So it sounds like it's pretty bad, and maybe we are I hope we're at the top of the peak then.
I feel like we're at the top of the peak. We won't know till next week, but I feel like we're at the top right now. The first number I heard was April 8th was going to be the peak for New Jersey, and now I'm hearing maybe April 14th.
Okay, which I think was what they were talking about for the peak for the whole country. I think I heard April 14th last week. So now, are you collaborating with doctors outside of the country? Are you collaborating in other states? Or is that all done at the hospital level and then the information trickles down?
Yeah, people don't communicate with each other as much as they should. Most of us always work in our own little silos. And, we're lucky if we share information. But, what's been happening is kind of like what happened with Hurricane Maria. When Hurricane Maria happened in Puerto Rico, all of these grassroots people came together and used social media to kind of share information and get efforts together through Facebook, Instagram, email lists, WhatsApp. Same thing's happening now with physicians with COVID. So I'm on like multiple different text threads with, a bunch of doctors that I knew from different hospitals across the country. I have friends that I trained with that are in Florida, California, all over the country. We're all sharing data. And information is passed on very quickly now. So we can all share information very quickly. And there's a bunch of emergency medicine docs are really good at like putting out the latest information. And so are, intensivists. So there's a lot of podcasts, there's EM Rap, there's a bunch of different podcasts coming out that constantly update the latest trends and changes in data. they have connections in Italy and they're speaking to doctors there and bringing that information back here. And we're just spreading it around kind of in a grassroots way as much as we can. So we're sharing it unofficially through social media and WhatsApp and text threads and emailing friends. And it's working. I think it's working a little bit. There's no coordinated consortium with meetings. I mean, some of the companies I work for have calls, company calls where they try to disseminate information. So there are efforts being made to share as much information as quickly as possible.
Now, the final thing I wanted to talk about, I'm not sure if this is something that doctors themselves handle, but when someone dies from COVID, if they have COPD or they've got diabetes or some sort of stage 4 cancer, but they come to the hospital with COVID and unfortunately they pass away. Do emergency room doctors or other doctors categorize how that death is? Because I know that people are concerned that miscategorizations from deaths are going to lead to a lack of clear information as to I guess it's the numerator and the denominator for the infection rate and the death rate and all of that. Right. So is that something that ER doctors are involved with or doctors are involved with, or is that an administrative/political decision that's done by hospital administrators?
That's a good question. We are involved in that. I do a lot of death certificates, and I know the medical examiner is overrun with COVID deaths. So, we're at the point where the policies are changing about what deaths need to be reported to the medical examiner because they are overrun with these cases. So if the patient definitely tested positive for COVID, right? If I have a positive lab test for COVID and they die of respiratory arrest and I see it and I pronounce them, I do the pronouncement, their death pronouncement. I'm writing the death certificate. So I'm writing cardiopulmonary arrest due to respiratory failure, due to hypoxemic arrest, due to COVID infection. And then I'll add maybe the other diseases they had, like COPD or diabetes or heart failure, if I'm aware of those extra diseases. If they were a person under investigation who died in the same way, who died of a cardiopulmonary arrest from a respiratory arrest, and I'm all pronouncing them, and I know that we tested them for COVID and it's not back, I will put suspected COVID as the reason for the death. Oh, wait 1 second, honey. I'll be right back.
Is there a spider in my head?
Nope, there's no spider.
Everyone's working from home now, so everyone's used to it. I think that my 2-year-old kind of snuck in here and was quickly taken out, so,
Oh, now I forgot what I was saying.
Death certificates and how you categorize it.
Yeah, so if they're under investigation, I put suspected COVID on the death certificate. These deaths all look like COVID. I mean, they all look very similar. I don't think they're being miscategorized. I think the COVID deaths are very clear. The problem with testing, though, is we're not testing asymptomatic people because why do we need to, right? Well, you're not symptomatic. You just want to know if you have it. We don't want to waste our time and money and efforts on an asymptomatic patient. So they weren't being tested. So that, it makes it seem like sicker people have it. We're testing all symptomatic people. And those symptoms vary from headache, fever, shortness of breath, chest pain, to like hypoxic, needing oxygen. We'll never have I don't think we'll have an accurate denominator because we're not testing everybody. And do we want to test everybody? And then what about the false negatives with the test, right? So you can't rely on the test that much. If there's what is the false negative rate of the COVID test? I don't even know I don't think they know it yet, what that number is.
No, but they do have that issue. They do have an issue with it.
Right. So, if I have a symptomatic patient who has an abnormal x-ray, who has classic findings of COVID on the x-ray, which is multiple bilateral patchy ground glass opacities, and they have fever and shortness of breath, I know it's COVID. I don't need the test. Most doctors feel that way. We know it's COVID. We don't need the test. We're doing the test just to kind of like help us close that deal. But we have all those other symptoms and imaging findings on chest x-ray and CAT scan that show us that it's COVID. So the test is, maybe a little controversial. We like the test. Hopefully the false negative rate's going to be low, and we haven't tested asymptomatic people, so we don't know what that carrier rate is.
And can you do that with antibody testing, which would obviously not be an ER, but is that something that we could do?
I don't know enough about the antibody testing. Very few places are doing it. I know Mount Sinai is offering antibody testing, but only for their employees, I believe. So it's not it's not widespread yet. It's still under a lot of investigation.
All right. Well, I think
it seems promising. People want that convalescent antibody donor to maybe help with the immunity of other people.
Now, here's one other thing. Can you have, is COVID, is the test for influenza, can it pick up on COVID as well? In other words, can you have influenza type A or B, but it's really COVID masked as an influenza? Or are they completely separate?
Two totally different kinds of viruses. We have rapid influenza tests, and we have respiratory panels where we test for 15 different respiratory infections, like generic coronavirus. There are 2 generic coronaviruses that have been in the population for a while: rotavirus, enterovirus, metapneumovirus, influenza A, influenza B. So those tests are separate, and then there's a specific COVID-19 test that's very specific. So no, there's no way it could mask. Initially, we thought there was a very low co-infection rate because they were taking the data out of China that reported the co-infection rate of coronavirus with influenza A or another virus was less than 2%. And I don't think that panned out. So initially we were testing people with symptoms with the flu first and saying, well, if they have the flu, they don't have coronavirus because there's a very low co-infection rate. And I think that turned out to be not true. So now we just test people for coronavirus. So we don't even know if they're being co-infected with the flu anymore because we're not bothering to test them anymore because the flu's not killing them, coronavirus is. So we're not wasting our laboratory resources on testing for these other viruses anymore. We're just testing for corona to make sure they're not going to die of coronavirus.
All right. Well, this has been very informative. Thank you for all the information. Is there anything else you want to add or say before we close this out?
There's still an upside. That we have extubated a few people, and we have released, like one hospital has discharged 96 people to home, and people have gotten better from the disease. And we know doctors, ER doctors who've gotten infected, who have recovered. We do know a couple of doctors that have died, sadly, of the virus. There was a doctor who was cited in the New York Post who worked at East Orange General, and he died of the coronavirus, and it's very sad. He was very well loved. And then there are doctors who have recovered and done very well, and there are people who've recovered and done very well and gone home. So there's a positive side to this very sad story.
All right. Well, I see that your son is pulling you away, so I'll let him do that. Thank you very much for your time. Thanks for coming on the show, and keep up the hard work. Stay safe and stay healthy.
All right. Thank you, Jason. We'll talk soon.
Okay. Bye.
Forget about the moon, the stars, and the sunlight. You're gonna get to know my